Welcome again. This is our second video about antihypertensive medications. Today we're going to discuss the beta blockers, the alpha-1 blockers, and the alpha-2 agonists. I hope everyone is ready. Now let's get started. Beta blockers are a class of medications that are used predominantly to protect the heart. They are cardioprotective medications. This is their main use right now. Most especially, they protect the heart against arrhythmias, especially after myocardial infarction. Patients following myocardial infarction have an increased risk of the development of cardiac arrhythmias. This is when beta blockers plays a major role in protecting the heart. Beta blockers can also be used to treat hypertension, even though they are no longer the first choice. Physicians currently prefer medications like calcium channel blockers, ACE inhibitors, and thiazide diuretics to treat hypertension because they have a more favorable side effect profile compared to the beta blockers. Beta blockers blocks beta-1 receptors and beta-2 receptors. And there is also, by the way, beta-3 receptors that's located in the adipose tissue. Blocking the beta-3 receptors decreases the rate of lipolysis. But let's focus here on beta-1 receptors and beta-2 receptors. The beta-1 receptors are mainly located in the heart and the kidney. Stimulation of the beta-1 receptors increases the heart rate and increases the contractility. Or in other words, it has a positive chronotropic effect and positive inotropic effect. Stimulation of the beta-1 receptors in the kidney leads to increased production of renin by juxtaglomerular cells. The beta-2 receptors are located in the blood vessels of skeletal muscles and liver, and this leads to vasodilatation. Also, beta-2 receptors are located in the smooth muscles of the lungs and uterus, and this also leads to relaxation of the uterus and relaxation of the smooth muscles of the bronchi of the lungs. Beta-2 receptors are also located in the eye, and stimulation of beta-2 receptors in the eye increases the aqueous humor production. So blocking the beta-2 receptors in the eye can be beneficial in the treatment of glaucoma. The first class of beta blockers are called beta-1 selective blockers because they selectively block the beta-1 receptors. They don't have effect on the beta-2 receptors. They work mainly on the beta-1 receptors. And if you remember, we said beta-1 receptors are mainly located in the heart and the kidney. And that's why these medications are called cardioselective beta blockers. These include medications like acebutolol, atenolol, ismolol, metoprolol, bisoprolol, and nebivolol. How can you memorize all these names and differentiate them from the non-selective beta blockers? I have a very simple rule. All the medications that starts with A all the way in the alphabets to N are cardioselective, and starting from N all the way to the end of the alphabets, Y or whatever, are non-selective beta blockers. So we only have N as a common point or a common letter for both class of medications. In the cardioselective we have nebivolol. In the non-cardioselective or the non-selective beta blockers we have another medication that starts with N. We're going to talk about it when we reach that point. Blocking the beta-1 receptors in the heart will result in a negative inotropic effect, which means decreased myocardial contractility, and a negative chronotropic effect, which means decrease the heart rate. Overall, this will result in the decrease in the cardiac output. Also, blocking the beta-1 receptors in the kidney will decrease the renin secretion, which in turn means decrease in the production of angiotensin and aldosterone, and this overall effect will result in decrease in the blood pressure. Blocking the beta-1 receptors also decreases the rate of lipolysis, and that's why beta blockers have some less favorable side effect profile in terms of lipids. They lead to some form of mild hyperlipidemia. So beta-1 selective blockers can be used to treat hypertension, and this is because they decrease the systolic blood pressure and the diastolic blood pressure through decreasing the cardiac output and through decreasing the renin release. Also, these cardioselective beta blockers, since they are cardioselective, we can use them for angina and coronary artery disease, and this is because they decrease the myocardial work. Also, they can be beneficial following myocardial infarction for the same reason, because patients with myocardial infarction have increased risk of the development of cardiac arrhythmias. Beta blockers or cardioselective beta blockers can also be used in heart failure, and this is a debatable use because a lot of physicians debate the use of beta blockers for heart failure, since heart failure patients have some form of increased sympathetic activity over time, blocking this sympathetic activity has been shown to be beneficial in patients with heart failure, and that's why beta-1 selective blockers are indicated in patients with heart failure, but not to the point to reach a decompensated heart failure. If we reach the point of decompensated heart failure, it's preferred not to use beta blockers, but other than that, beta blockers can be used in congestive heart failure. So beta blockers or cardioselective beta blockers can be used in hypertensive patients with concomitant heart disease or ischemic heart disease. In this context, they can be very beneficial and they can be a first choice. The next class of beta blockers are the non-selective beta blockers. They are called non-selective because they block both beta-1 receptors and beta-2 receptors. These are older beta blockers compared to the other classes. These include medications like propranolol, the first one in this class, timolol, pindolol, nadolol, sotalol, and cartulol. If you remember the rule we said in differentiating the non-selective beta blockers from the cardioselective beta blockers, we said any medication that starts in the alphabet A all the way to N is in the cardioselective, and from N all the way to Y is in the non-cardioselective. And we only said there is one exception to this rule, is the N in the cardioselective is represented by nebivolol, and the N here is represented by nadolol. There is only one exception to this rule, which is the cartulol. The cartulol starts with C and it's in the non-selective class. Other than cartulol, this rule is easy in differentiating the cardioselective from the non-cardioselective beta blockers. These non-selective beta blockers obviously will have more side effects compared to the cardioselective because of the blockade of the beta-2 receptors. For example, the bronchoconstriction. Non-selective beta blockers can be used in indications like hypertension, angina, myocardial infarction, just as the cardioselective beta blockers for the same mechanisms. But because the non-selective beta blockers also block the beta-2 receptors, they have more indications than the cardioselective beta blockers. For example, the non-selective beta blockers can be used in portal hypertension. And this is because blocking the beta-2 receptors in the liver blood vessels will reduce the portal blood flow, so this will reduce the incidence of complications like esophageal varices. Also, we can use them in hyperthyroidism because they reduce or they ameliorate the symptoms of hyperthyroidism like anxiety, tremors, and palpitations. So for the same reason, we can use them in tremors like essential tremors, or anxiety, post-traumatic stress disorder, or social phobia. Non-selective beta blockers also used in glaucoma because blocking the beta-2 receptors in the eye will reduce the aqueous humor production, so they will reduce the intraocular pressure. Propranolol is a highly lipophilic drug. It achieves high concentrations in the brain, and that's why most of these indications that has to do with the nervous system, propranolol is the most preferred agent. And that's why propranolol can sometimes be used in the prophylaxis of migraine headaches. Finally, non-selective beta blockers can be used in pheochromocytoma. And this is because pheochromocytoma are tumors that secrete catecholamines like epinephrine and norepinephrine. So we have to block both the beta receptors and the alpha receptors. So we need to use both beta blockers and alpha blockers. We should not use beta blockers alone because this will leave the alpha receptors unopposed, and this can lead to hypertensive crisis. The next class of beta blockers are beta blockers with intrinsic sympathomimetic activity. Sympathomimetic means they have some sympathetic agonist effect, and that's why they are also called partial agonists. These medications express both agonist activity and antagonist activity. How is that? Basically, this depends on the concentration of the drug and the concentration of the natural agonist in the body. In high concentrations of the agonist, they will act as blockers. In low concentrations of the agonist, they will express partial agonist activity. So they will express partial sympathomimetic activity. So for example, if we have high concentrations in the body of epinephrine, in that case, they will act as blockers. So they will decrease the heart rate. On the other hand, let's say we have low concentrations of the agonist. Let's say we have low concentrations of epinephrine in the body. In that case, they will act as agonists. They will increase the heart rate. Examples of these medications include pindolol and acebutolol. And I have a good news for you because I also have a nice way to memorize these medications. These medications, as I said, are partial agonists. PA. P, pindolol. A, acebutolol. So these medications can be beneficial to some patients and non-beneficial to others. So for example, they can be useful in patients with excessive bradycardia from the beta blocker use because they will increase the heart rate to some extent. On the other hand, to some patients with angina, we should not use them because increasing the heart rate in patients with angina can be very dangerous. The last class of beta blockers we're going to discuss are beta blockers with alpha blocking activity. These are the newest generation of beta blockers, or the third generation beta blockers. The two famous examples are carvedilol and labetalol. The alpha blocking activity causes arteriolar vasodilatation, and this will result in rapid reduction of blood pressure. Carvedilol is used in congestive heart failure and left ventricular dysfunction, along with ACE inhibitors and diuretics. Patients with congestive heart failure have increased sympathetic activity, and by blocking this increased sympathetic activity, we improve the myocardial function. Also, by causing arteriolar vasodilatation and reducing the blood pressure, the ventricles need to pump blood against less resistance, and this also improves the myocardial function. Labetalol can be used in hypertensive emergencies and hypertension of pregnancy. Labetalol use in pregnancy is safe, so labetalol is safe during pregnancy. There is a mnemonic for medications that can be used during pregnancy. We're going to discuss them later on. Both of these medications can cause postural hypotension, obviously because of the arteriolar vasodilatation, and bronchospasm because of the blocking of the beta-2 receptors of the smooth muscles of the bronchioles. Both of these medications should not be used in patients with severe bradycardia because they can lead to heart block, patients with heart block because they can aggravate the heart block, decompensated heart failure for the same reason, diseases causing bronchospasm because they can aggravate the bronchospasm. General side effects of beta blockers includes bradycardia and hypotension. The old non-selective beta blockers are very lipophilic, so they can cross the blood-brain barrier and cause side effects that's related to the central nervous system like fatigue, dizziness, and depression. Also, beta blockers can lead to insomnia, and this is because of the blocking of the melatonin synthesis, especially the propranolol. Also, beta blockers can lead to erectile dysfunction, and this is because sympathetic nervous system plays a role in erection. So by blocking the sympathetic nervous system, this can lead to erectile dysfunction. Now, there are two effects of the beta blockers on diabetic patients, depending on if the patient is type 1 diabetic or type 2 diabetic. In patients with type 1 diabetes, beta blockers can mask the hypoglycemic symptoms, and they can even reduce the blood glucose level. And this is because of the blocking of the beta-2 receptor mediated glycogenolysis and gluconeogenesis. So this will result in reduce in the blood glucose level. Masking the hypoglycemic symptoms, because patients with hypoglycemia will develop symptoms like tremors and anxiety and irritability. These side effects or these manifestations will be blocked by the beta blockers. So we have to be careful in using beta blockers in patients with type 1 diabetes. On the other hand, patients with type 2 diabetes, beta blockers can increase the insulin resistance or decrease the insulin sensitivity, and this can lead to elevated blood glucose levels. So, bottom line is, the effect of beta blockers depends if the patient has type 1 diabetes or type 2 diabetes. Beta blockers should be used with caution in the following conditions. Patients who intake alcohol, because both can lead to hypotension. Patients with asthma or COPD, the non-selective beta blockers can exacerbate their conditions, because by blocking the beta-2 receptors, this will result in bronchoconstriction. Patients with type 1 diabetes or type 2 diabetes, they can have some unfavorable effects with the beta blockers as we discussed earlier, so we have to be careful. Patients with severe bradycardia, the beta blockers can result in severe heart block. Also, decompensated heart failure, the use of beta blockers is not favored. Patients with severe peripheral arterial disease, we should not use beta blockers because the blocking of the beta-2 receptors of the peripheral arterioles will result in peripheral vasoconstriction, and this can exacerbate the symptoms of patients with severe peripheral arterial disease. Finally, beta blockers should not be abruptly discontinued, as this may result in the precipitation of withdrawal symptoms and increase the risk of cardiac death. If we want to wean off the beta blockers, we should wean off the beta blockers gradually, not suddenly. The reason for that is with the long-term use of beta blockers, there will be an upregulation of the number of the beta receptors. So with the abrupt withdrawal of the beta blockers, there will be massive stimulation of these receptors, and this can result in sudden death. The last point about beta blockers is the overdose. The symptoms of beta blocker overdose includes trouble breathing, blurring of vision, palpitations, lightheadedness, and low blood pressure. The treatment of beta blocker overdose includes glucagon, because glucagon antagonizes beta blockers by increasing the intracellular level of cyclic AMP. Remember, the beta receptors are GS receptors, so they increase the intracellular level of cyclic AMP. So beta blockers will antagonize this effect, so they will decrease the intracellular level of cyclic AMP. Glucagon antagonizes this effect by increasing the intracellular cyclic AMP. So in that case, glucagon can be useful in beta blocker overdose. Also, anticholinergic bronchodilators like ipratropium can antagonize the bronchoconstrictor effect of the beta blockers. Now let's switch gears and talk about alpha-1 blockers. Alpha-1 blockers include medications like prazosin, terazosin, alfuzosin, and the new medication tamsulosin. By blocking the alpha-1 receptors, this will result in vasodilatation and decrease in peripheral vascular resistance. And that's why alpha-1 blockers are useful in the treatment of hypertension, peripheral vascular disease, and erectile dysfunction. Also, blocking the alpha-1 receptors of the smooth muscles of the bladder and ureter will result in vasodilatation and relaxation of the bladder and ureter. So this will improve the urine outflow. Patients with benign prostatic hyperplasia, the enlarged prostate tends to compress on the ureter. So this tends to decrease the urine flow. So by blocking the alpha-1 receptors of the ureter and bladder, this will help to improve the urine flow and help to improve the symptoms of patients with benign prostatic hyperplasia. So this is another major indication of the use of alpha-1 blockers, especially the newer alpha-1 blockers that's more selective for the prostate, like for example the tamsulosin. Tamsulosin has more selectivity for the alpha-1 receptors in the prostate without affecting the blood vessels. So it's the main treatment in patients with benign prostatic hyperplasia without hypertension. In patients with hypertension and benign prostatic hyperplasia, yes, we can use the other alpha-1 blockers like terazosin, alfuzosin that can work both on the blood vessels and the prostate. So in patients with only BPH or benign prostatic hyperplasia, we prefer to use tamsulosin because it's more selective for the prostate and not on the peripheral blood vessels. The side effects of alpha blockers includes hypotension, which can lead to the feeling of dizziness, weakness, and headache. Also, alpha blockers are famous for causing what's called first dose orthostatic hypotension, which means sudden severe drop in the blood pressure when the patient changes position from lying down into standing. We can avoid this side effect by giving the first dose at bedtime and titrating the dose up. Also, alpha blockers, since they cause hypotension, they can lead to reflex tachycardia and palpitations. There is another side effect called floppy iris syndrome, which can happen during cataract surgery. Finally, alpha blockers can lead to what's called retrograde ejaculation, which means the retrograde movement or the backward movement of semen into the bladder. And this is happening because of the relaxation of the smooth muscles of the urethra and the bladder that helps to facilitate the backward movement of semen into the bladder. Finally, the last class of medications we're going to talk about today are the alpha-2 agonists. The alpha-2 receptors are located in the presynaptic terminals. So these are alpha-2 receptors. What's the function of these alpha-2 receptors? They inhibit the release of norepinephrine in the form of a negative feedback. So basically, the norepinephrine that's already released into the synaptic clefts binds into these alpha-2 receptors and blocks the further release of catecholamines. So in that way, this is called a negative feedback. The most famous example of these alpha-2 agonists is clonidine. Clonidine is a medication that's used for resistant hypertension. We don't usually use it for regular hypertension because of the many side effects. In addition to resistant hypertension, clonidine can also be used in attention deficit hyperactivity disorder. This is a disorder that happens among kids. So by helping calming these kids down, this will help these kids to focus more. Also, clonidine can be used in drug withdrawal symptoms of alcohol and opioids. These patients will display agitative symptoms, so clonidine helps to calm these patients down by reducing the levels of catecholamines. The problem with clonidine is that it can cause rebound hypertension, actually rebound severe hypertension with abrupt withdrawal. And this is because of the sudden surge of catecholamines again into the circulation after the discontinuation of clonidine. So it's first of all advised to withdraw clonidine gradually and not suddenly. And if this happens, we should never use beta blockers alone, because if we use beta blockers, we will leave the alpha receptors unopposed. This will lead to massive severe vasoconstriction of the alpha receptors and massive hypertension. Clonidine was used historically for a test called clonidine suppression test to diagnose pheochromocytoma. It's no longer used nowadays because we have better tests now to diagnose the pheochromocytoma. Basically what happens is clonidine in normal individuals will be able to suppress the levels of catecholamines in the circulation through the negative feedback. But in patients with catecholamine secreting tumors like pheochromocytoma, the clonidine will fail to suppress the levels of catecholamine in the circulation. Finally, alpha-methyl-dopa is an alpha-2 agonist that can be used safely during pregnancy. We have reached the end of the video. Thank you everyone for watching, and please don't forget to subscribe. There is also a Facebook group called Medical Boarditis. You can check it out for more information and more high-yield board material. Thank you again, and see you next time.